A patient sustained an injury to the right thumb while playing football. He injured the thumb while in the course of a game. On clinical assessment, there is a swelling and deformity of the thumb. The base of the thumb is tender. There is swelling, but the skin is intact and neurovascular status is normal. X-rays were done which shows oblique intra-articular displaced fracture of the base of the thumb metacarpal. Now in this scenario, the differential diagnosis can be Bennett fracture, pure dislocation of carpo-metacarpal joint, Ronaldo fracture, metacarpal shaft fracture, or carpal fractures itself. The diagnosis was obtained by a radiograph which shows a Bennett fracture. The most common mode of injury for Bennett fracture is motorbikes or cycle accidents, where forcing the handlebar into the web space between the thumb and the index finger. Other injuries can be sports-related, fighting, or fall on outstretched hand. Generally, any trauma causing abduction and hyperextension of thumb can cause Bennett fracture. It's most commonly in men, and the peak incidence is the age 35 to 45 years. While talking about the surgical anatomy, the articular surface of both trapezium and thumb metacarpal are saddle-shaped. The CMC joint is formed by the apposition of these two saddle joints with the axis of each at 90 degrees to each other. These allow minimal constraint and good range of motion, especially compared to the other CMC joints. In Bennett fracture, the volar ulnar portion of the metacarpal is held in place by heavy ligamentous attachment, whereas the shaft is displaced proximally by the pull of the abductor pollicis longus. The distal fragment is rotated by the adductor pollicis brevis and flexor pollicis brevis. Although this is not a weight-bearing joint, the high compressive stresses places it at a very high risk for degenerative arthritis. Thus, the saddle shape of the articular cartilage should be restored as perfectly as possible. Now, there are multiple modalities of management. The distracting forces of abductor pollicis longus causes instability in Bennett fracture. Traction can be used to counteract these displacing forces. Regarding treatment, close reduction or percutaneous bending is possible. Open reduction internal fixation is a possibility. Extensor fixator application is a possibility. Or a direct conservative management with the casting is another option. A new option would be arthroscopic assisted fluoroscopic percutaneous technique as well. While talking about the close reduction and percutaneous K-wire fixation, a transverse extra-articular fracture can be treated with a transarticular K-wire fixation. A oblique extra-articular fracture can be treated with intermetacarpal K-wire fixation. The complication specific for this treatment will be a loss of reduction. In open reduction internal fixation, a volar approach as devised by Gedda and Moberg is most utilized. Thinner muscles are reflected volarly and a longitudinal capsulotomy is made. Fracture is clamped in a volar dorsal plane. Fracture is provisionally reduced with K-wires and fixed with a screws or a T-plate depending on the fracture pattern. The complication specific for this treatment is injury to the superficial branch of the radial nerve. Wound healing can be an issue, and adequacy of anatomical reduction predicts the development of radiographic arthritis but does not predict symptoms of arthritis. External fixation has been primarily used in case of Ronaldo fractures, which is a comminuted fracture through the base of the thumb metacarpal in a Y or T-shape. Similar in the case of severe instability of multiple digits injured, external fixation can be used to reduce a Bennett fracture as well. The external fixation is applied to the fragment, traction is applied, and length and alignment are maintained by tension band wiring. While performing arthroscopic assisted close reduction and fixation of this fracture, a percutaneous cannulated screw is a possibility. The patient is placed supine using a general anesthesia, accentuation of arm and tourniquet control. To begin, a longitudinal traction is applied through a finger trap to the thumb with the 10 to 12 pounds of traction. A mini fluoroscopy unit should be placed horizontally around the hand, assisted in placement of percutaneous guide wires. A 19 gauge needle is used to make a portal in the dorsal CMC joint. A skin incision is made over the needle. Blunt dissection to the thumb CMC joint with protection of a superficial radial nerve is done. A blunt trocar is used to enter the joint. A 2.7 mm 30-degree angle scope is introduced. Through the second portal, a small joint shaver is used to remove the clots, and a limited synovectomy is performed. The fracture is now observed. The displace of fracture is reduced using longitudinal traction. Percutaneous guide wire is placed in the metacarpal and directed towards the avulsor fragment. With longitudinal traction, pressure is applied to the base of the thumb. This maneuver levers the displaced proximal fragment to the reduced state, countering the distracting forces of abductor pollicis longus. With the reduction confirmed by mini fluoroscopy, a guide wire in the distal metacarpal is driven into the proximal fragment, securing the reduction. A depth gauge is used to select the appropriate screw length. The guide wire is then overdriven into the adjacent trapezoid bone, which helps to place a cannulated drill to be used in preparing an implantation of screw without loss of reduction. A countersink is used in the distal metacarpal segment to permit placement of a buried washer. A cannulated washer is then driven until it is firmly seated beneath the bone cortex. Next, the cannulated screw is placed. Occasionally, a second screw is required for rigid fixation, and the process is repeated. Arthroscopy confirms articular alignment of the fracture, and mini fluoroscopy confirms architectural orientation of the metacarpal and a good position of the implant. Skin incision is used with 40 nylon scissors, and thumb spica is applied. Anyhow, post-operatively, the joint is protected for 3 weeks of cast. Hand therapy is begin with removal of splint in 3 to 6 weeks and serial radiographs at 6 weeks and 6 months. All these methods of management have advantages and disadvantages. While talking about arthroscopic reduction, percutaneous fixation is a minimally invasive intervention. Reduction is under arthroscopy, and radiographic visualization with stable fixation is achieved. If this helps in early active motion, the disadvantage is technically demanded. There is some argument that the cannulated screw can cause inflammation and can cause tendon problems. Close reduction and plaster immobilization is a non-invasive intervention. There is a high likelihood of loss of reduction, and long-term osteoarthritis is a potential problem. Loss of function is also possible. Close reduction and percutaneous spinning is minimally invasive and a greater stability than closed methods. Longer immobilization is required, and there is a discussion regarding K-wires exposure can cause more chances of infection. External fixators helps permit stable fixation of complex wounds, especially open fractures and community fractures with dynamic fixation may allow early range of motion. Technically, external fixator is demanding at CMC joint, and there is a high risk of infection.